Hi, I'm Mike Schmidt, Ensemble Ventures. We're back for our healthcare IT segment, and we're in for a treat today because we're going to bring in 3 different professionals in Colorado that are managing and pursuing this healthcare information exchange and records management for patients at the Colorado level, both at the state and local and city level. And this is part of our workforce enablement seminar series that we're putting together. In our previous sections, you've heard other speakers and other professionals in this area. We're going to focus today on healthcare IT. And with me today is Mark Carlson. He is the Director of Strategic and Product Development at the CORIO, which is the Colorado Regional Health Information Organization. And I think, Mark, you've been there about 5 years so far.
That's correct.
And had some time with Reed Group and also with McKesson. You were a consultant in the healthcare space there. Tell us a little bit about that.
Certainly, yeah. I was with McKesson for 8 years, started on the technology side, but moved into working with large enterprise systems and how to best strategically deploy, acquire different solutions within McKesson to enable health information exchange at the system level with specific McKesson tools.
Very good, very good. And you're also a UCC grad, I understand.
Yeah, excellent. My undergrad there, and
you did
masters at CU.
Masters at CU. So obviously Colorado stock here,
yes.
And we're pursuing down this pathway. Mark and I, this is actually the first time we've met face to face. We've talked in the past and seen each other at shows, but never really had a chance to go down this engagement path. One of the things I found amazing when I started doing the research on CORIO, and again, this is the healthcare information exchange at the state level. Right now, and I think Mark's been a part of this performance so far, 54 hospitals have been connected. 4,000 providers now. This is 8,600 total users, so that's a pretty sizable number in terms of a state healthcare exchange, and 4 million patients in the overall record base.
That's right.
Is this the top 5, top 3 in the country?
I think we've been identified on some national publications as being within the top 5 in progress at a state level within health information exchange.
Very good, very good. And I was kind of running through your dashboard here. This will also be available on our microsite in addition to this interview. This is one of the things about the Workforce Seminar Series. Not only will you be able to see the interviews, but you're going to be able to dive deep in some of the materials and research and documentation. So you'll really find this quite amazing. Basically, over this time span in terms of CORIO, they have connected most of the major community health chains and hospitals. One of the things that I was a little interested in finding out about, Mark, was have you been able to get CORIO down at the community level, like safety net medical clinics or some of the independents? I mean, I know this has been somewhat of a challenge. Is CORIO and working with some of the other local agencies to do this?
Yes, we are. I mean, we rely, our success has been built on community development. And really at the forefront of the community development was the federally qualified health centers, so the FQHCs across each community, who were among some of the first non-hospital connecting groups within the network. So we've had some great success working within the community access groups to be able to engage those audiences and stakeholders.
Excellent, excellent. And on your website, you guys have some pretty good maps that show where most of these centers are located. Basically, I think it's a drill down map, and people can see if there's some of these hospital chains that are on your network in the area.
That's right.
I did notice there was an interesting electronic health record connectivity status, and for the audience, EHRs are electronic health records. They're really the upgraded personal health record. You might have a personal health record that you use for your day-to-day stuff, but again, the EHR is really an expanded health record. And what I found amazing about CORIO is just the sheer number of healthcare record connectivity that you guys have done. Would you say, Mark, that this is easily 25, 30, 40 different types of EHR platforms so far?
Yeah, I think we've connected to 32 unique EHRs, some very small, some that have not been able to keep up with the mandates and changes that have happened in healthcare, which I think represents one of the challenges for physicians. But we have been able to find great success, especially with a number of the large vendor organizations.
And I notice there's a couple in the pipeline, another 6 that you're bringing on. You call them in your yellow category. So a little bit. And is this predominantly been used in the API area where you're trying to develop unique types of APIs to reach out to these EHR platforms, or is it? I mean, I know Epic had for many years as they started out was keeping things tight to the vest.
Right.
And has the industry started to open up a little bit and start working with API models to do this connectivity better?
Well, I think API connectivity touches on that next generation of connectivity. How we established 5 years ago, really the standards of technology were HL7 transport. So it's basically a interface to electronically transfer. Right now what we send are ADT, so demographic information, admission and discharge information from the hospitals,
right.
Lab results in discrete form, so that HL7 connectivity defines the ability to identify each data element and send that out electronically. So that's micropathology, general labs, blood bank come out of the hospitals, as well as transcription. So the imaging studies, the H&Ps, discharge summaries, ED encounter notes, those all came through an HL7 connection out of our HIE platform.
Right.
And we connected that directly into the EHRs that are reflected on that list. As we move forward, that next generation creates more of a bidirectional interaction between a source system and a physician office, so that to better cater and deliver information upon request. And I think that's one of the big challenges we confront.
It's a huge challenge. And I know about 3-4 years ago, I was talking with a number of the safety net medical clinics in the community, and a lot of them have not been able to really benefit from the HIE technology because of the cost and expense.
Yeah.
And I think we might even be talking with Jim Kalani later about the CHP's work and trying to get this community interface. And I know you're working with a number of community organizations, and even with Memorial Hospital, when it was taken over by the university system, they made a transition from an older system to, I guess I could say, version A to version B. I don't want to mention the vendors, but were you guys involved in helping shepherd that through that process when they made that cutover?
No, not specifically. University came with its own technologies in place, and really their goal was to unify all their system on the same solutions.
Both in Denver and in the Springs.
It certainly had downstream planning and impact that required us to work closely with them to ensure that there wasn't an interruption in how physicians and practices that depend on the information were receiving it.
Well, it's funny, I was talking with Henry Lewis. He was being interviewed by, I think it was Jennifer Hugo in one of our other sessions, and they were talking about some of the I guess you could call it trials and tribulations of making that cutover. He stayed on actually 3 years to make sure that that cutover happened. So it's really not an easy process. There's a lot of data work and integration work that has to be done. And I can see, in Colorado, because of the unique nature of these organizations, you guys are having a lot of interplay and intercommunications between these various bodies. So, and I've looked at and researched in other parts of the country, and I think Colorado, up and down the Front Range, we are getting our act together. We're not out of the woods yet, but I think we're making a lot of tremendous progress.
I would agree with that statement. I think Colorado is the reason we've had the success we've had is I think there's a number of factors, but I think the most important was the collaborative environment here. Obviously, these are competing health systems in the open market.
Absolutely.
But I think there was a early on agreement and understanding amongst key leaders within each of the large systems and hospitals across the state that we're not competing on the delivery of data. We might compete on quality of data or how we use the data, but there was an agreement that data sharing was a priority for improvement in healthcare across all systems.
Very good, very good. Well, let's dive into the weeds a little bit. I'm going to read you a study that was done about the effectiveness of HIEs. And studies have found that the adoption of HIE has risen sharply in recent years. 76% of U.S. hospitals are now exchanging information electronically. This was in 2014, an 85% increase over 2008. However, on the other hand, as of 2012, only 38% of office-based physicians are using HIEs and using those, and less than 1% long-term care providers are using electronic health records. So is this gap in the utilization down at the street level, down with physicians who are doing the day-to-day battle in doing this healthcare for their patients? Is there still an adoption rate that's not caught up with the forecasts?
I would agree that I think even in this state, which has had great progress, and as we mentioned earlier, probably in the top 5 in connectivity, however, that physician active provider user count is only about 45 to 50% of the physician market here in Colorado. So there is still lots of work to do. And I think the key becomes, yes, the aggregation of data is important and the access to it is important, but in managing all the change that is happening in healthcare right now, driving clinical value out of that information at the point of care so a physician can use it easily to make clinical decisions is the challenge that we are confronting now.
Interesting.
And I think that's where the next hockey stick of adoption comes, because I think a lot of our adoption has come with the FQHCs and large primary care groups who have more of a global need for the information that's shared. When you get down to specialists, it's much more specific, and what I want to see as a specialty physician in the clinical information that's coming to me, and that becomes a very different challenge. And I think the adoption will grow as the capabilities to be more targeted in how that information.
Well, you know, it's interesting, the whole purpose of meaningful use as it came down through the ACA pipeline, you know, it's gone through these three phases. And I've read a lot of trade press recently about, you know, is meaningful use really that meaningful anymore? And then also these new techniques and standards that are coming in the market, like MACRA, which is now a new approach model to do this. And do you see that these new, is the dials being changed at the end of the game here to try to fix the problems that weren't addressed in the first pass?
Yeah, I
don't know if that's a good way to say that.
Well, no, I think I get the gist of your question, Mike, and I think because I do think it begins to address how at the federal level and the ONC, Office of National Coordinator, are trying to address the adoption issues. Part of what is important to gaining more adoption is you have to align it with the interests of the physicians and the practices and the patient. Patient is an extremely important component of this, and I don't want to leave that train or ignore that train. But specific to MACRA, it's aligning payment mechanisms to the use of data to help manage your patient population. So manage your chronic diabetics, to manage your higher cost patients and create more visibility. So the MACRA concept is a way of trying to shift now how Medicare, Medicaid would pay out for how you're managing a patient population. So a pool of money versus fee-for-service where I'm getting paid just for various activities along the care continuum.
And this initiative at the local level for community networks is really going to be a key component of that, to be able to bring together various types of unique, different providers. So you've got not only traditional care, you know, alternative care, behavioral care. There's a number of people coming to the table now where you even have family members that need to be part of these collaborative care networks. And I can see, you know, that getting this down at the grassroots is so vitally important. And hopefully, you know, when we talk to Jim in our next interview, what he's trying to do at the CHP level, we'll cover that. So enough of the policy stuff at the high level. Let's kind of drill down to some areas of concern that you have. You had mentioned to me this idea of the value-based care landmines exist everywhere in the marketplace. Do you want to elaborate on what you believe these landmines are? And
sure.
Yeah.
I certainly can. So I think inherent with what we just touched on with MACRA and that whole push to go to more of a value-based payment mechanism. So I'm paying for outcomes for an entire episode of care versus a simple reimbursement for a lab draw, for office visit. But to be able to manage that kind of risk from a physician level, it requires organizations behind it. If you look at smaller practice groups and independent practices, they might not have the infrastructure required to be able to manage that to that level against a large risk-based contract. That's where partnerships with somebody like Community Health Partnership, CHP, are so important, because they're deploying infrastructure and tools such as care coordination, care management services to help with management of that patient after they've been discharged from the hospital, or when they've shown up at the ED for the third time in a month, and to be able to sometimes arrest those behaviors so that you can get them engaged with their primary care provider, or to just help with general patient education and engagement. The physician can't do everything. And creating that visibility, the promise of real-time data and doing it in a more targeted and meaningful way also requires back-end support and management, and that's where these large organizations come in. But I think the biggest challenges in the short term is that the health system isn't truly equipped to be able to receive and handle
actually do that.
Handle all
well,
of that.
And this has really been kind of an argument in the industry, whether, do we put all this stuff in a big SaaS cloud and try to manage it with big data analytics, or do we still have a local data depository that's, fairly much owned and managed and run locally by not only physicians, the patients that are providing the data, the providers. We've got this local data that we're massaging. Yes, it can be uploaded to, clouds for anonymized data usage and research for pharmacy-based research networks and so forth. But I believe, and I've had this conversation with Mike Ware at El Paso County Medical Society, they are really concerned about having security on this data, keeping it local, but being able to still share it with national organizations.
Yeah, and I think you bring up a couple of important points there, Mike, because I think critically, data security and use is extremely important, especially for a public HIE. So if you're looking at commercialized uses of pharmaceuticals doing prescription use, rate of prescriptions at given offices, we don't intend to or want to go into that world, and the communities would not. I think there would be concerns with that. So we're very focused on the clinical uses of that data.
Perfect.
The partnerships that we establish within the communities are essentially to build out the best technologies and back end to help deliver to the community needs. And I think that's where our focus needs to be. Certainly, many of the public HIEs didn't last after federal funding.
That's right.
And we are certainly sustainable in our core operations now, but we do look for avenues in how we can to invest in other technologies to ensure that we can grow and achieve some of the goals that I touched on earlier.
Very good. Well, listen, I really appreciate high-level HIE from the top down.
Yep.
What I'd like to do now is kind of shift real quickly to the purpose of our Workforce Enablement Seminar Series, and that's really to engage the public so that they understand what some of these healthcare opportunities are. And I've kind of got a set of questions that we're going to ask all of the interviewees, and then we'll come back together with this pilot or a panel session at the end. But overall, what we like to know, and let me just find that quick note here. Find that. Yes, here it is. All right, so one of the things we're interested in learning from you from a HR standpoint, because obviously you're looking at this from an operational view, is from your experience in what is the kind of caliber of professionals that are coming to you, whether they're existing healthcare IT professionals that have had some time in the saddle working on some of these challenging areas versus, say, the caliber of the college graduates that are coming out and want to break into the healthcare IT space. What are you looking for in terms of skill sets, capabilities, experience, and where are some of the soft spot areas that you think have huge need that maybe some of these people can start targeting?
So there's certainly, let me address I think what some of the skill sets. I think there are a number of programs that are developed across a number of the colleges across Colorado for clinical informaticists.
Got it.
I think understanding of the clinical data and the challenges that provide that the barriers that exist is critical in helping work at a data level when you're working on the technology side.
Very good.
I do believe that what we've found that there are a good background in understanding the challenges with aggregating and making meaning out of data.
This is one of your analytic areas that we talk on. Yeah.
So if we want to deliver targeted clinical information out to a primary care provider to inform them on their chronic diabetics, such as most recent A1C or the fact that happened.
Right.
One of the biggest challenges in healthcare is the variability of that data across the spectrum.
Right.
That each health system has unique ways of naming and coding that data. So when we receive it, when you aggregate it, it's not necessarily a one-to-one ratio.
Right.
What one hospital system might call an HgA1C, another one might call hemoglobin A1C with a totally different code. So the skill sets to be able to understand data and then be able to provide solutions to making that data meaningful for targeted end state delivery. And So I think that's one of the,
Yeah.
the key
The other kind of round out question was: has any of the university systems or key college programs that are focused on healthcare, have they reached out to you to inquire or explore some of your needs from the workforce standpoint, or do you want to see more of that contact happen? Because again, that's one of the purposes for this whole series,
Yeah.
is really open up the door to the professionals in the industry, but also to really identify these key challenges that we have in each of our communities. So
Yeah.
would you want to see more of this contact happen?
Oh, I agree, because I think healthcare is unique. Sometimes it suffers from terminal uniqueness, that, and there
Terminal uniqueness. Let me write that down. That's right.
but every need is, we have to find the macro level commonalities, but I think most certainly experience in healthcare or exposure or even an outreach program at the local level to help young
Very good.
college students understand what is happening in healthcare and what are some of the key pieces of understanding that should
Absolutely.
be acquired to make meaningful solutions. Everybody wants to say, well, why don't we just exchange it like we do in banking? I walk up to any ATM, I can get money out.
Yeah.
Well, a dollar is a dollar in any
True.
accounting
well,
system.
and this was the concept of healthcare record banking that kind of shot up on the radar about
Yeah.
10 years ago.
Right.
I would have loved to see that have happened, in terms of how that could actually really basically put the physician and the patient in the driver's seat in terms of that information. That's going to be an area we'll explore in another topic area. But Mark, listen, I really appreciate you spending the time with us
Yeah.
today. I think
Thanks
we
for the
covered some
opportunity.
good stuff, and we'll look for you on the panel here coming up. But more importantly, I want to make sure that you can provide any of your documentation or research, whether it's part of this interview or things that you feel our community needs to have. Send it to us, and we'll put it right up on the microsite.
Yeah,
Thank
absolutely.
you, sir. Appreciate your time.
Likewise.
You bet. And that's it for our initial interview for the Healthcare IT session. We've got 2 more to go, plus the panel. Looking forward to it. Thank you.